Hi, good afternoon, everyone. We're here for this afternoon session, Bad Rad and What Drives You Mad. The conveners for today, Dr. Aditya Daftary and Dr. Nirad Vengsarkar are here with us. And I know it coincides with the lunch session, so I don't know about what our attendance is going to be like, but let's start anyways, and we can have, the conveners start the proceedings.
Okay, thanks. So let's do one thing. Let's try and get all of our panelists up on front, which means there'll be nobody left in the audience, but we'll just work with it that way. We have actually a good group of radiologists and orthopedic surgeons. We have Dr. Shah, who's finishing his coffee. We have Dr. Prashant Meshram, who's here. We have Harshal Bamb, who's on the spine side. Premik has not shown up yet. Ankita Ahuja is another one of our musculoskeletal radiologists. Chintan Desai is still smoking a joint somewhere. And Nikhil Iyer is here, but he's left his joint for a couple of minutes. And Dr. Abhishek Gorlawar. Okay, so great. So Premik has shown up finally, and Chintan. So now we have all the seats filled in for the panelists, and there are absolutely no seats for the participants. But we can sit anywhere and we'll go through stuff. All right, so the idea of this session was just to go through some common things that we see in practice that bother us on imaging, and to get a sense of how different people will approach different things. I'm going to get the timer going. Nirad, do you have a sense of the timer?
Yeah.
Okay, so we're going to do this as a case-based module. There are 10 cases that we're going to try to get through, and we're going to try and poll both the radiologists and the orthopedic surgeons on what they think about these cases and why they think about it that way. So this is the first case. We're going to first take about 10 seconds to poll the audience. So Nirad, if you want to start the audience poll quickly. It started. So if you have your phones and if you've QR coded in for this room, you'll be able to use Slido to put in some these things. We'll have an N of 0. Okay, all right.
I think we just, we'll have to skip this.
Okay, we don't have too many. But if anybody is on it, we can do it. We may not show the results. Okay, so let's just have... let's have the non-spine faculty that actually does general, anybody who does general orthopedics here, who can take a look at this case and just sort of think about how would you look at this case in terms of what do you think on this MR that this is a case of, is it infection, ankylosing spondylitis, an end plate fracture, or like a Schmoll's node?
Okay, can I pick up people?
Anyone can start. Harshal, why don't you go for it? What do you think?
So for me, it looks like an infection.
Okay.
There's a, I think, 5-4-3 anterior superior corner at L3. On T2, it's lightening up. On T1, it's hypointense. On a coronal image, the superior end plate shows the thing, and you can see a slight abscess also in a coronal image. And also, the axial images shows the loculated abscesses. So for me, it looks like a infection.
Right. Anybody else have a different thought on that? Anyone else would be thinking of something else when you saw something like this? Okay. Can we have the lights down also just in case that do this? Okay.
The other thing to be thought of if we wouldn't have seen the abscesses would be ankylosing spondylitis, but I think with the abscesses it becomes infection.
Yeah. So I think the key things that we wanted to drive home with this case is that infections typically start at the end plates. They're also the best area for biopsy yield when you're doing biopsies. When you see edema and end plate irregularity, these are, I think, some common things that we come across on scans all the time. But always look for the soft tissue component. The soft tissue component is kind of important when you see either an epidural or an anterior prevertebral soft tissue. That's an important thing for us to look for. Especially if it looks liquefied, then be more concerned. Sometimes with an end plate fracture, you may see a small hematoma anteriorly, and that may be mistaken for that. So that's what you want to think about. Now, there's a whole list of things that happen at the end plates. And what I'm going to show you some examples of different things. So this is our case in point, where we had the end plate changes here. For those of you who didn't see it. And then you can see this paraspinal soft tissue here as well as here. And therefore, this actually ended up being infection. But here are some other cases. So for example, here also you have a case where you can see these end plate irregularities. And one might easily start to think that this could be an infection. And unfortunately or unfortunately, these have sometimes turned out to be infection. But for the most part in this case, this is just an acutely exacerbated Schmoll's node, which can look just like this. Here's another sort of example where you can see end plate irregularity. So sometimes when you see on T1 and T2 weighted images, you can see sort of this this fatty appearance on both sides, then these are normally degenerative end plate changes, which you will see with modic changes. And sometimes you can see sclerosis with them. And in those cases, that's again type 3 modic changes. Here's another example where you have edema anteriorly. You don't see a lot of soft tissue. You can see that edema sort of diffusely going across horizontally here, and you don't see a big prevertebral soft tissue. This is just a subtle sort of anterior end plate compression fracture. So where there's not actually been any compression of the vertebral body. So typically this would be the patient who comes with acute back pain after a fall. You do an X-ray, everything looks normal, and they say it's still hurting, and you get this, and you get an image that looks like this. And here's sort of another example of somebody where you can see here again an inferior end plate fracture here with, again, just that little bit of soft tissue anteriorly here, which is just the hematoma. Finally, here's another example where you can see those end plate Schmall's node, and this is actually probably the one that you really do want to pick up. So when you see those contiguous end plate Schmall's nodes and you're starting to think that this could be acute exacerbation of a Schmall's node, remember always to look at the posterior corners, okay? So in this case, you can see on the T1 and T2 weighted images, the posterior corners are bright. And this is typical of fatty metaplasia that you see with an inflammatory spondyloarthropathy like ankylosing spondylitis. So when you see vertebral end plate changes, obviously in your head, the first thing is infection, and should I rule that out? The second thing would be like a Schmall's node or an acute compression fracture. But the third thing that you must keep in mind is if this could be ankylosing spondylitis. So look very carefully for the corner changes in the vertebral bodies, and that'll really help you make that call, and that's where you'll actually make a real difference to somebody. Okay, so here's a second case that we have for today. Anybody want to take that? Abhishek, you want to try that? What would you say for this?
It looks like a fracture there. Just follow it up. Nothing. Just follow it up.
Okay, so your thought, and why would you say that?
Number one, there is a drop in the height of the vertebral body, so there's collapse for sure.
Yeah.
There's a horizontal line there. I don't see.
What is the horizontal line? Do you have a pointer there with you? No. Okay. So there, when you mean this horizontal line here?
On the,
So this horizontal line here.
Right there, what we see on the stir-weighted imaging.
This line over here.
The anterior one.
This?
No. A bit more above. You're going to above. It's okay.
Sorry.
Fair. There's a bit of a small amount of prevertebral soft tissue.
This prevertebral soft tissue, right?
No, that one not.
And this little bit here?
Yeah, the small up there.
Okay.
And the posterior vertebral body margin, if you see the collapse, it's not showing that classic concavity we see with infections and something. For all practical purposes, I'd like to know what was the history of this patient first.
Okay, this is just came with back pain. Old lady had
fall?
Yeah, a little bit of a fall, maybe.
Now you're toying with us.
Standard. I'm telling you a standard story that I get with every MR. Nothing different from what you've seen or what you get in your practice.
So most likely it looks like a fracture. Follow it up.
Okay, so you think you would classify this as a benign fracture, and the reasons you're calling this a benign fracture are because. What are your main reasons why you're saying this is a benign fracture?
I could see a good amount of preserved vertebral marrow along the end plates.
Okay, so you see, so when you look at this marrow, you see this dark signal over here, and here you see this marrow looks very similar to this marrow here. So that's what we call preserved marrow signal. Okay.
Quite a preserved vertebral marrow there.
Yeah. What else?
Not much. A very small amount of prevertebral soft tissue. Not much of
a little bit of prevertebral soft tissue. But we were saying prevertebral soft tissue is something that makes us think about infection.
We do also see sometimes in cases of collapse of vertebral bodies. We do see sometimes fluid collections anteriorly.
Yeah, and that's because of
fluid collections secondary to fractures.
So like a hematoma or something that forms typically post-fracture, right? Exactly.
Actually, image would have really helped us in seeing whether there is a circumferential fluid or there is just a small.
Let's say there was circumferential fluid.
Okay, then I'll still go for follow-ups.
Okay, all right. Okay, cool. Any of the spine guys want to add something to this?
Follow-up by now.
3 weeks.
3-week follow-up. Anything else you'd like to do?
Probably CT.
Okay. How about you? Anything?
Again, here the history is important. The duration.
The history is dicey.
Yeah,
the same that I get, you get.
Again, duration of symptoms also help us whether to go further. But follow-up is the right choice. And secondly, that posterior superior corner, which is going back, which is classical of an osteoporotic vertebral compression fracture. In malignant fractures, you typically see all those
more
convexities in the
concavity. Yeah. Great, perfect. Great, convex.
Ballooned up.
Yeah. Premik, anything?
Nothing. I'll just check for myeloma profile.
Okay.
That's the only.
You would check that in this case.
For any osteoporotic fracture.
Okay. Okay, cool.
That's what I had to ask. Whether it
Sorry.
is the same lesion if you are getting in 45 and 65. Is
The
it
entire
it
approach
makes
change.
any difference?
Yeah. I think there,
65 you must have to go to myeloma profile.
Elderly, yes. Myeloma is always a profile to work out.
okay. And the other thing is that, again, 45 to get this, then you're definitely thinking there's abnormal underlying bone if there is no significant trauma.
Yeah.
Right? Okay.
So as I say, history.
Yeah.
Here's the history.
Okay, so here's just sort of comparison between, just to show you examples of how benign and malignant compression fractures differ from each other. So if you look at this is a malignant compression fracture. You can see this is a very convex appearance to the posterior aspect of the vertebral body. Here it's almost a geometric piece of bone that's gone behind. Okay, so this is what will make you think that this is more of an acute or an osteoporotic compression fracture or a traumatic compression fracture as opposed to a malignant one. So the way I try and simplify this for people is if I tell you that if you were to think of two cardboard boxes that you had, one that was filled with styrofoam and one that was empty. If you sat on the one that's filled with styrofoam, you will notice that it bulges. So that's the one which has got all tumor cells. So you think of the styrofoam as tumor cells within it, so it will just be bulged like that. Whereas if you think of sitting on an empty cardboard box, you sit on it, it will just angulate and crumble. And you'll get sharp vertebral margins at the end. So that's what you tend to see when you have a osteoporotic compression fracture, with a sharp vertebral collapse over there. Also, when you think about the biomechanics of vertebral compression fractures, especially in an older person, there will be an element of exaggerated kyphosis. So there'll be compression anteriorly, and you see multiple compression fractures happening together sometimes. Okay, so that's another thing you'll see with osteoporotic ones, whereas metastases tend to happen in different spots. And metastatic fractures will tend to happen when there is a significant involvement of the vertebral body. So if you have a small metastatic lesion, typically you're not going to have a pathologic fracture. If you have a large amount of vertebral body involved, then you'll think of a pathologic fracture. So here, for example, you can see this. Here you have a lesion in the lower vertebral body here. There's no fracture because it's just a small amount of the vertebral body that's involved. Here you see very diffuse involvement of the vertebral body, and therefore you can see that this is sort of a more malignant one. And here you can see that the lesions are scattered. They're not sort of one with, here you can see on the other hand, there's somebody of multiple vertebral body fractures happening sequentially, and therefore this is sort of altered biomechanics related. Another thing that we talked about was spared marrow signal. So again, if the vertebral body is not significantly involved, it's unlikely to fracture. So if you see a lot of spared or normal marrow signal like we saw earlier, then you would think of somebody. So here you can see this marrow signal is normal. But here you can see that this marrow signal is quite abnormal. There's no normal marrow signal in this vertebral body. And so that's more likely a malignant fracture. Some little tricks that we use with imaging, we use something called in and out of phase imaging, which can sort of help with telling separates fat from the adjacent soft tissues. And if you can see fatty marrow, then you know that this is more likely a benign fracture. Okay. Also, when you look at posterior vertebral body involvement, so if you see a metastatic lesion, typically it is because of mets that deposit along the slow flow areas of Batson's plexus. So they typically start at the posterior aspect of the vertebral body and then spread to the pedicles, and that's why you get that winking owl sign on X-ray as one of the early signs of a met. Whereas a vertebral compression fracture tends to be more anterior and will tend to have more edema but not so much soft tissue involvement posteriorly. So here, for example, you have a hyperflexion injury. You can see posterior involvement, but it's because of the jumped facets. And here, for example, you have a vertebral lesion. You can see the paraspinal soft tissue component and extension into the pedicle for that lesion. Also, we talked about this prevertebral soft tissue. When you see a compression fracture, it can be circumferential and it will be like that, but with this it will be larger and more irregular. So here's an example of somebody who's got a tumor, and you can see how that tumor involvement is much bigger. So these are just some common things when we talk about it. The convex posterior border. If you see a linear band, as Dr. Gorlawar pointed out, that there's one little linear band of bright signal in the fracture line, then that's very good. If it's a discrete fracture line, then that's pretty typical for an osteoporotic compression fracture, as opposed to if you just see a crumbled edematous vertebral body. The epidural mass we talked about. If you have a large sort of asymmetric one, you think more of something that is post lesion. But if you just see a small homogeneous thin one, then that could be a post-traumatic hematoma. Okay, so let's just go to case number 3. How about this one? So here we're trying to ask everybody this is a pretty typical meniscal tear. I'm just going to see, you can see this linear area here. This is a coronal image. This is your medial femoral condyle, medial tibial plateau, and you see this line over here. And this is the axial image showing you this line running this way. And I think here the questions are, would somebody ignore, repair, resect, or do a PRP for this lesion? So any of the arthroscopy guys want to take a crack at this?
So the way I see it is this is a peripheral kind of tear with in the red zone, which goes very well with the repair for me. And these guys do really well, but the rehab and everything is something to discuss. This is a vast topic, of course. But in my practice, this person gets repair, especially if symptomatic, especially if young. Another thing I would like to add is like in old patients with arthritis, if they come with this, then that becomes a little controversial, because what we try to tell them is if we repair or resect with a meniscal tear, if someone who has grade 3 arthritis, we tell them you may improve. We try not to operate on them. We tell them even if with the best of the surgery, your pain will not go away because the part of the problem is the arthritis. Okay. So I'm going away a little bit, but I want to make sure that if this person is young, he gets a repair. If older, osteoporotic, then I would have a discussion and come.
What do you think this guy is young or old?
Looks young.
Young.
Hey, young cartilage looks good.
Okay.
In man's, I think it's a repair for him.
What about you, Jay? Any thoughts? Repair. Okay, is there anything else you guys ask for before? Yeah, go ahead, Hital.
It depends on what I find. Sometimes I tend to leave these repairs, this meniscal just like that, no resection, nothing, and amazingly they are never symptomatic. I think we are unnecessarily putting those arrows for no reason. I have lots of cases, almost in 80% of such cases, I don't do anything. If they are stable, I just leave them alone and nothing happens to them.
That's a great point,
You're
actually.
talking about in your clinic if you look at the MRs.
No, during the surgery, arthroscopy, if they are
And
stable.
you're doing the arthroscopy for what?
They are ACL together. They
Okay, you're
have
talking about associated.
associated this thing.
So if they have an ACL, I'll repair because it's an unstable knee per se.
It's a stable one. Really, there is no need to do that. And I have personally experienced these patients. Never, even after 3 years, they come to me. They are perfectly fine. Once you repair, you are going to put them in non-weight bearing. And that creates a problem. They develop flexion deformities. They develop their rehab is delayed. Lot of they cannot go to work for next 6 weeks. And when you are doing only ACL, the rehab is much faster. And I have personal experience of more than 50 cases where I have not touched them, not repaired, not resected, and they do well. Of course, they are stable one.
If you repair and make them walk, what will happen?
I don't know. I don't want to have a
what I
broken
mean is-
arrow inside troubling them.
No, I mean, if weight bearing is not a problem, but as well just put a stitch and make them walk. I mean, if you're not worried that.
So
without
normally when you
repairing,
put those
nothing will
arrows,
happen.
I don't know what will happen to those things. They may be loose bodies, nothing. So why put something when it's not necessary?
Fair enough. I think.
And the radiologists want to just chime in quickly. We'll get back, but just chime in quickly on when you're reporting these cases. What do you think about putting in your reports? Anyone? That would potentially be helpful.
Yeah, so first of all, the location, what parts of the meniscus are involved, and then yes, the zone, red, white, or pink.
Okay. Anything else in terms of other things that you would consider that we do in our
Associated
practice?
cartilage,
Yeah.
but in this case, obviously the cartilage is looking very good, but we want to look at the cartilage, especially if it's associated with injury, then you comment upon the ACL and everything, and posterior horn roots in case of an
let's just say we
elderly.
have an isolated meniscal lesion. What are the typical things that as a radiologist you want to mention in the report because you think are useful to the clinicians?
So you want to mention what type of tear it is. Obviously, that
Okay.
is going to make a difference. So longitudinal tears, what I understand is most likely they go for repair peripheral.
So simple or complex geometry would be
Yeah.
the first thing. Okay, next.
Then is there any associated root tears if they impact the management?
So the characteristic of the underlying meniscal tissue itself, does it look like robust meniscal tissue? Does it look like degenerated meniscal tissue?
Yes.
Anything else?
Then the cartilage.
Okay, cartilage. If there's cartilage loss or not.
Yes.
Because obviously if there's plenty of cartilage
Advanced.
loss, then that ship has sailed and maybe there's no real reason to
Yeah,
do
like
that.
he already said that
Right.
if there is
Anything else that we
cartilage
talk
thing,
about?
Then if root tear, then we talk about extrusion and
Right.
everything.
So any
the
meniscal tear,
quality.
we want to talk about extrusion because that could basically be a cause of you've got a loss of hoop strength. And if you have a fair amount of meniscal extrusion, then you're probably not so well off trying to repair those menisci.
And lastly, the associated injuries.
Yeah, so I think the things that we look at when we look at longevity of the tear, Ankita, you want to just sort
So
of...
we want to look at the meniscal tissue quality. So if it's really degenerated and bad quality, then we know that this was something which has been over a period of time. And usually what I've seen is longitudinal tears, peripheral longitudinal tears are usually associated with injuries and they are not associated with that bad quality of the meniscus.
Go ahead.
You made a very good point, actually. I like that. The question I have is, how do you decide it is stable or not? You probe it.
Yeah.
And then, how much moment is when you decide unstable or not? Because I'll tell you, for me, if it comes until the center of the condyle, or a little less, I would think of it to repair or not. If it comes to the center of the condyle, that's a repair. So how do you decide it's stable or not?
So basically, as I said, if it's unstable, you feel that it's coming into the condyle and then I would be more on a repair side.
Right.
But just because it's a tear, sometimes even complete, the peripheral tears, they tend to repair on their own.
Yeah.
And I think most of the good results of meniscus repair are because they are anyway going to heal.
Yeah.
So we unnecessarily give ourselves credit to that.
I think healing you see more on the lateral side. Many a times when you go a little late, you've seen a
No,
tear which is
because
already
I feel
healing.
when you are doing all this is mainly when you have anterior cruciate ligament tear, right?
Exactly.
So, and when you are making those tunnels, you are already putting BMPs there. You are already putting healing substance. This menisci heal very well.
So
And
question from the audience.
One
Sorry.
thing I
Okay.
wanted to ask you.
Just say. No.
Discussion means that asymptomatic tears should not be treated.
Yes, so I mean, we have an old saying, we use it in radiology all the time, and most of the time the orthopedic surgeons taught it to us, is that we don't treat MRIs, we treat people. So
But my
it's
point
basically
is,
how the patient appears.
If question now,
Yeah.
I have had the opportunity to see some post-repair ACL menisci after say 8 years, 10 years,
Yeah.
properly repaired, but those menisci are not retorn, but they are degenerated, and where it is reported by someone that the mass is completely reduced.
Yeah.
So whether it is really worth repairing so how do you prognosticate? Can MRI help us?
So this is exactly the point. So here's what we are coming to. So this is at least what we follow generally, at least what I've learned in our practice, is if somebody comes in with strong meniscal signs, has a simple geometry to the tear, so it's a linear longitudinal tear going typically through the red or the red-white zone, with good tissue quality, so we don't see intrasubstance mucinous changes within the meniscus itself. Usually acute traumatic. If it's a more chronic meniscus, it's less likely to heal well. If it is the cartilage is normal, invariably in our practice they will do a standing AP standing radiograph of the knees to make sure that there's no overt varus or valgus loading, which could unnecessarily overload that thing. We look at whether the alignment of the knee is neutral. We look for the presence or absence of extrusion. So if there's extrusion, then your outcomes are a little bit worse. And then we look for bone edema also. So if there's bone edema, then you're not sure how much of the symptoms are coming from the bone edema as opposed to how much are coming from the meniscal tear. So I think if you're checking off all these boxes right, then you have a very symptomatic meniscus from an acute lesion in the periphery with a simple geometry, with normal alignment, then your outcomes tend to be excellent. Whereas on the other hand, if you have a negative in any of those boxes, really you need to think twice before you go ahead and do a meniscal repair. And this is where sort of MR helps us in giving us a reasonable number of those check boxes as being available, and then obviously you have to add the clinical components to where we're at with it.
Aditya, you can add age box also in this.
Yeah, so age box generally goes into where we look at...
Almost all grade 3 osteoarthritic knee will...
Oh, so that's where you said cartilage. So if the cartilage is gone, then we're not going to. But today's day and age, the other thing is because we see so many more active people, we've seen people at 70 who have phenomenal cartilage. So there's no reason you shouldn't deny them a repair if they are supposed to, if they've got an acute lesion. Right.
Generally, along with ACL, there are lateral root tears.
Yeah.
But they are often missed on MRIs. Why is it so? Is it true?
So lateral root tears are not typically missed on MRI. I think where you, well, in the sense that when you get reporting, but the idea really what happens with the lateral meniscus, unlike the medial root. Actually, one of the Ankita or any of the radiologists, would you like to take that question?
Medial is diagnosed quite often. The
So the lateral root goes a little more deeper and in. So I think it's the person who is seeing might not be focusing in that area, but it's not missed with good quality images. You can really well see the lateral tears.
So do I need
And
to instruct my radiologist to
So
like,
we-
which cut or something, sequence something to do? For
So we have a high resolution protocol. So what we have observed in most of the places, they do large FOV images. In those images, you cannot see things really great. So you reduce your FOV and do a high resolution images, you can definitely see. What we prefer in our practice is PD weighted images without fat suppression. But I think if somebody is used to, they can see on fat suppressed as well. But PD weighted images without fat suppression is something which we use in our practice. And usually, also, in addition to root, we see commonly Risberg rips as well in that. And that is also very well picked up on MRI.
confusion whether it is intact or not, I think.
So I think I think the point over here really is that when you look at the Risberg lateral meniscus junction, you can see a linear high signal in it. And sometimes what happens as a radiologist, you just have to learn to follow it more towards the periphery. And when you follow it more towards the periphery, you see that tear extending towards the periphery of the meniscus as opposed to being just towards the midline. And that's when you raise the possibility of a Risberg rip. And I think a lot of radiologists sometimes blow by that because we know that's a normal area for us to call an artifact or to call it as not really being a tear. But if you notice that cleft between the Risberg ligament and the lateral meniscus for too many sections laterally, then you have to start thinking that there's a Risberg rip tear.
One more thing what you can do, that when you write for prescription for MRI, you can just mention in the prescription 3 mm sections, small FOV. Once you put that in the requisition there, then the radiologist know that the orthopod really knows what he's looking for in the joint. Small FOV, 3 mm sections, and most of people get it okay.
I think the simpler thing to do is just write what you're looking for.
Yeah.
Because we never get what you're looking for. It's only the phone call later. यार इसको तो ये है तुमने बताया ही नहीं. ऐसे तुमने तो बताया नहीं कि तुम ये देख रहे हो. बाकी सब
Most
तुम्हें
of the
बता दिया.
prescriptions are like pain in the knee joint, MRI knee joint.
Yeah.
What do I do with that?
Yeah. So I think that's sort of often the thing. Okay, let's just keep going ahead. So here's another one for the arthroscopists. So ACL here, torn, not torn, and there's this image, these three sets of images. So here you can, let me see this. Here you can see the ACL, here's the ACL, here's the femoral attachment. And I'm going to go one more axial image here, down, so you see this here and up here.
Looks like a posterolateral bump.
Okay. So the options are, is it a tear, partial tear, intact, or mucoid?
Partial tear.
Partial tears, partial tear. Anybody else? Anyone else have a thought on what this is? Partial tear, partial tear.
Partial tear.
Yeah. Okay. So this is kind of in terms of the eye case here. So what happens with these cases is, I think one of the things I want to show you here is what does a normal ACL look like? Now, many of you will get fat suppressed images. Many of you get T1 weighted images. The reason we use proton density non-fat suppressed images is because it shows you very good signal to background between the ligament and the adjacent fat. If you have a fat suppressed image, the ligament is dark and the fat is dark. So it's very difficult to differentiate, especially in chronic issues. So when you look at this here, you'll see this is the normal ACL on the coronal plane. This is the axial plane. As we get to the top of the intercondylar notch, you can see this thick sort of robust ACL here. And here's the sagittal plane where you can see the ACL here looking more vertical than Blumensatz's line. And Blumensatz's line is the line that runs along the posterior aspect of the intercondylar notch. So you can see that these two, the apex of the angle is at the top. If we go back to this case, you can see this is Blumensatz's line and the ACL. You can see this ACL has dropped down a little bit. So it's a very subtle finding, and we run across these every now and then. The only reason I bring this up to you is because these are the classic cases where you say, yaar, pura ACL lacks and you have called it a normal ACL. And then you say, I went into surgery and I saw the ACL was completely torn. And this is why your radiologist may not pick it up sometimes, either because they're using fat suppressed images, they haven't paid that much attention to that. And it's not a fault of anybody, it's just an easy thing for everybody to miss. I think more that people know about it, the better it is.
Aditya, one question here.
Yeah.
Do you feel that adding something like a traction image or something that
Listen, you can pick these
any value?
So I think we have a standard way of solving things is by adding one thing more, instead of just going back and looking at the things you already have a little bit more closely. There's this, people have done these oblique ACL images for years, and they've shown time and time again that they don't add anything except waste time on your scanner. So there's...
I think again a clinical history of Lachman's test would be good for the radiologist.
Yeah.
That what are you suspecting?
So this is a good case because this is something which we see in the clinic, and we are wondering because if I see it, I feel it's lax, and if my partner sees it, he says like, grade 2. So grade 2 zone is what is clinical kind of. What helps us is the buckling of the PCL.
Yeah.
That's number one sign which we look for, number one. And of course the clinical correlation. So do you think that buckling of PCL?
So I'm going to show you, I'm going to show you a bunch of things that explain a lot of those things right now. So here's the first thing is I think for you to just be familiar with what the ACL looks like on the coronal plane, on the axial plane. Now here I want you to focus a little bit on the axial plane here. You can see this thick, robust appearance of the ACL here. As you go a slice down, you can see it maintains that thick, robust appearance. This is the double bundle appearance of the PCL. And then as you go down, this is more the tibial attachment. So this is what your normal ACL looks like. If you look at this is a T1 weighted image and this is a proton density image. And you can see just by looking at the different sequences, the ACL looks so different. So it's important that you look at the right sequence. In today's day and age on internal derangements, we hardly ever do T1 weighted images. So you must make sure you look at the proton density image where you can see the ACL really clearly. Common clues that we look at. So if I see this typical sulcus terminalis, posterior lateral tibial plateau, posterior medial tibial plateau, bone marrow edema, then I'm reasonably sure that something is wrong with the ACL. It may be low grade, it may be intermediate grade, it may be high grade. So this is the one thing that I look for almost always, which helps me to tell that probably the ACL is gone. The ACL itself can have a varied appearance. So here you have a normal sort of striated appearance. Here you can have something that's got early mucinous degenerative change. Here's moderate mucinous change. Here's a full thickness femoral attachment tear. Here's a chronic ACL where you don't see the ACL at all. And here's the buckled PCL. Now, when it comes to the buckled PCL, I think an important thing to remember is a buckled PCL is because the tibia has translated anteriorly in relation to the femur. That does not happen in every ACL case. As you know, there are copers and non-copers. So copers may not even actually be anterior translating. So you may not see the buckling of the PCL. The second thing that happens is when you put somebody into an MR scanner, we put them in a coil and we pad them. So we might actually realign their knee a little bit more. So you may not see a subtle translational difference in that. So while the buckled PCL is a good sign if you see it, but if you don't see it, it's not necessarily something that is this thing. And also sometimes we see a buckled PCL appearance in somebody who does not have an ACL tear. So I don't hang my hat on a buckled PCL.
Can we differentiate, having said that, partial ACL tear?
Yes, so I'm going to show you.
Which bundle has torn?
Yeah, so this is exactly what I'm going to show you now. So this is one more thing that happens. A lot of radiologists tend to call these striations at the ACL tibial attachment as being a mucoid ACL. And the reason is the femoral attachment of the ACL is narrower than the distal attachment. So the fibers fan out. And when they fan out, there's synovial tissue that intersperses in between. And that perfect timing, Dipit, don't go. The next case is a shoulder case. And so you see those striations in there, and that normally is just normal ACL tissue, and that gets overcalled as mucoid or low-grade sprain. Now, this is a case where you can see that typical translational bone marrow edema, and when you look at the ACL, it looks normal. Now, when you look at the axial images, what you can see here, this is the anteromedial bundle, this is the posterolateral bundle. And you can see the anteromedial bundle is heterogeneous and irregular. The posterolateral bundle looks great. Compare it against somebody who's got a normal ACL over here, and compare it somebody who's got a low grade or an ACL sprain at the femoral attachment, where both bundles look a little bit lighter and a little bit heterogeneous. So this is sort of how you can differentiate your partial ACL tears in these patients. So you see the classic bone marrow edema, and then you look for these other two things. Some other things that can help us, especially in chronic tears where you're not sure the ACL is torn or not, you see sulcus terminalis depression. Sometimes you can see bony remodeling at the lateral tibial plateau, which is the residual of a Sigond fracture. So that's the other thing that you can see sometimes. Okay, great. How about this case? Anybody wanna? Yeah, go ahead.
On the ACL, can it be the other way around? Sometimes clinically we don't feel it is
all the time.
ACL, but MRI reporting as ACL tear is 100% ACL.
No. So that's the key thing. You have to remember whether somebody calls it partial ACL, complete ACL. And the question, so because the partial ACLs, oftentimes people are just overcalling any signal hyperintensity in the ACL. So you just got to be careful whether that actual signal hyperintensity ACL is a real thing or is just within the realm of normal. And also mucoid ACLs can have that varied appearance.
Just one comment on that, good question. The thing is, we have seen this a lot, like, there's a grade 2 translation. We are not sure the translation is not there. But when you look at the MRI, there's a complete attachment from the femoral. We have seen that. It especially happens when the meniscus is intact. All right. In this case, you have to carefully do the pivot shift test And the pivot shift usually shows rotatory kind of instability, and those are the cases which probably needs like surgical. So you got to do the complete physical exam, because if the meniscus is intact, they will still not be completely translating anteriorly.
What will be the drawers in such case?
The drawers, as I said, the drawers is not, it's grade 2. It's not completely, when you compare on the opposite side, it's a very gray zone, and it's also, I think the inter-reader or, inter-rater reliability is kind of very low in that case. Like, if someone does it, it happens to us all the time. So our fellows, our residents or whoever are doing it, they say that, sir, it is not lax, and when we do it, it's there. So it depends on a lot of things. So
okay, so let's...
Pivot will be more helpful. Pivot shift will be more
pivot shift, I think we have understood, and we had this, I'm sorry taking too much time, jiu-jitsu player who had this kind of the same issue, and he had the PCL, we thought he had the PCL tear, and because his posterior translation was there, right? We checked, the rotatory translation was not there. When we went inside, the PCL was gone and the ACL was also gone. So the anterior translation was not there because his meniscus was intact. So luckily we had, we had to take graft from, you got to prepare yourself for taking more grafts. So going inside, I think we need to prepare when patient has something unusual like PCL. They may have posterolateral corner, they may have ACL, which is not showing on the clinical exam. So we got to be a little, and especially if they're chronic, they have the ACL, the torn ACL is completely attached to the PCL. So there's no way of making out unless we go in and check. So we got to be prepared for this.
So the one reason we quickly know that we oftentimes don't see ACLs on the draw, you don't see positive, is if there's a bucket handle tear, because the bucket is blocking your translation. So that's one thing that we've noticed oftentimes. Okay, so let's have any of the shoulder guys take a look at this. What would you do with this, Chintan?
So yeah,
depends on if I'm going on vacation next month or not.
That's true, especially if it's a cycling trip.
There you go.
Conserving. So this one looks more to me like chronic tendinitis, because I can see a little bit of probable calcific focus over there on the top image. The tendon, definitely we can see some fluid seeping in there, so maybe probably associated with some partial tearing there, but seems to be quite reduced, and depending upon the history of the patient and seeing about how is range of motion, what is the pain and all those things, would I then secondarily probably base my decision of operating or not operating, or any of those decisions as you've mentioned there. I don't know.
So I think you would probably say you'd need more information.
I would definitely will to follow up and see.
Okay. Nikhil, you want to take a crack?
Looks more like a tendinosis picture to me.
Okay.
With the fluid seeping in what we call as the interstitial tear, as it is reported most of the times. This is not a complete tear, so of course we'll need more information than 2 images, but mostly conservative would be my first plan.
Okay. Darshil, would you like to chime in with anything?
I think so. What Sir said makes sense. Initially, I thought it may be an articular sided tear because of a partial articular sided tear because of fluid seeping in, but more or less conservative.
Okay. All right. Great. So you want to go ahead?
There's just in the inferior image. There's also
because you're not running out of your time. That's well allowed to you. Huh?
Sorry.
Just kidding.
There's an acromial spur which is being there.
Yeah.
And we treat them conservatively, but we keep them in a close follow-up, because these are the patients who will come back and say that okay, it went fine. Maybe we get a steroid injection. Subacromial pain, it went fine. But then now I just cannot sleep in the night. When you sleep in the night, or with the particular moment, impingement kind of comes in. So we got to keep them in a follow-up.
I don't think I would worry about that spur too much.
Okay. Cool. We have the boxing ring in the back. You can just go and sort it out. Okay.
You can join us too.
I'll be the referee. Okay, so what I wanted to actually just use this as an opportunity is just to show everybody how MR looks at tendinopathy or ligaments or generally collagen-based tissue. And here the idea is that when we see collagen or good tendon, it's collagen fibers that are really well ordered. And when we're looking at MRI in most situations, what we're trying to see is if water molecules are mobile. So if we apply the MR signal and the water molecules move, then we get signal from it, and that tells us that water molecules are mobile, right? If you have a well-ordered tendon, then typically water molecules should not move and that tendon should appear black, okay? As you start to develop degeneration within the tendon, you'll start to see a little bit of high signal within it because those water molecules start to move. Now, based on how much mobility there is and where the mobility is, you'll get a sense of whether it's tendinosis, whether it's a tear, or whether it is articular-sided or bursal-sided. And that's essentially what we're looking at. So here, for example, is somebody who's got mild tendinosis, and it's primarily bursal-sided with a little bit of fraying, and you can see a little bit of fluid over here. Here's another example with more significant or moderate tendinosis, along with some intrasubstance degenerative change and a little bit of subacromial bursal fluid. This is more sort of critical zone. Here's an example with someone you can see where the deep fibers are completely intact, and there is a tear of the 50% bursal-sided fibers at the humeral attachment. So this is what Dr. Narvekar likes to call an anti-pasta lesion. So pasta lesion coming more at the articular side, and the anti-pasta lesion coming more towards the bursal side. And these ones, I believe, are hard to pick up arthroscopically, especially if you go intra-articularly. So these are the ones where you need to do a subacromial scope as well. It's also something which apparently does quite well with surgery. But oftentimes these small tears in this day and age, people are operating less and less on. So that's one thing. Here's an example where you can see the superficial fibers are intact, but the deep fiber has retracted. And these are the ones that are easy to miss for most people. So the footprint tears and this. Not that this would be surgical and not that this would be surgical either necessarily, but they would both certainly give you cause and be able to explain to the patient what their problem is and how you're going to manage them. And here's the last example where you can see a torn retracted tendon, full thickness tear, retracted to the glenohumeral joint. So the point of this case really was to demonstrate how tendinopathy looks on MR, and you could take this supraspinatus tendon out and you could apply it to the medial collateral ligament, you could apply it to any other tendon, you could apply it to the ACL, you could apply it to the PCL, you could apply it to any collagen-based structure that is well-ordered collagen to demonstrate how that pathology dynamically changes. I'm going to skip this case just in the interest of time, and we'll just move to something that's a little bit more.
Chintan, which of the this tendinosis is the best candidate? You delivered lecture on intra-articular injections. Which is the beneficial candidate for intra-articular injection?
I think all of them. Probably all of them is what I would treat with if I'm doing conservative.
Aditya,
yeah.
Just one question. Do you ever get the clinical information before you report? Because nowadays the
I'm a radiologist. I don't get any clinical. I don't get any clinical error. I never get clinical.
Little pain here and there, and people order MRI.
Yeah.
So which of there are multiple painful points on this shoulder.
Right.
So which of them are clinically relevant? Because we are just discussing, oh, this step maybe repair, or this thing maybe injection, but no one is.
Yeah. So what we end up doing is, rarely we do get clinical history. When we do that, then we sort of try and say, same is true of spine when reporting spine. Somebody says somebody has right lower extremity radiculopathy, then we'll say this disc is the most likely cause of the current symptoms. And similarly, if we get a patient, we see an MR, we may see a bad tendon, but we also say that the patient has 6-month history of restricted range of motion and diabetic, and we also see changes of adhesive capsulitis, then we would say, consider. So we tend to put things more in the consider, and obviously there's a full thickness tear, we'll mention it as a full thickness tear, but I think what we try to do based on the clinical information we get, we order our conclusions differently. So sometimes I might put the supraspinatus tear as the last point, especially if it's advanced osteoarthrosis. I'll say advanced osteoarthrosis, chronic tear, superior migration, blah, blah, blah. So we try to do that, but we can only do that if we are given some information to do that. Yes, sir.
Do you think a radiologist should examine the patient before reporting the MRI?
Yes. In fact, I'm starting my own OPD now. I've decided to start an ortho OPD, and I'll be seeing. So I have now decided examining everybody, and I've opened my own ortho OPD now. So I do all the diagnostics. If it's surgical, I just send it to the surgeon. Otherwise, I just manage them conservatively. So technically the term today to be used is tendinosis, more because they don't see that many inflammatory cells. Although histologically sometimes they do see inflammatory cells in some of these cases. In general, the term that everyone has now deviated towards is tendinosis. Tendinitis tends to be if you know specifically there's inflammation associated with it for any other reason.
And if you're confused, tendinopathy.
Correct. Always. Always find the middle ground.
So just one question. A lot of these tendinosis patients and partial tear patients, they have periarthritis.
Yes.
That gives a similar picture to adhesive. So what is your threshold on calling it an adhesive capsulitis changes seen? Because many of them do have...
So for adhesive capsulitis, normally, would you like to go ahead and Abhishek, some heads
As you said, I'll first ask the patient how is the restriction of the range of movement, duration of the lumbar, and number two, I'd like to see two very classical sites. One will be the rotator interval, and like to see what's happening in the inferior axillary recess, because these are the two locations where adhesive capsulator tends to have more involvement than the rest of the generalized capsule involvement. If I see more like सब कुछ जा रहा है, okay, periarthritis सब कुछ है, इसको छोड़ देने का. And then of course then call up my very good orthopedician friends and ask them, boss, gochi kya hai? And they tell me the history, and then I'll sort it out then.
Okay, I have one question here. A lot of different radiologists like to report those partial tears, naming them different things like high grade partial thickness or low grade partial thickness. I want to put it to rest. Like you like to report it in terms of percentages.
Yeah.
Someone else reports it differently.
Yeah.
For us, clinically, it may make a difference at the end of the day if we are injecting them or operating them. So, what, in your opinion, today, let's put it to rest, whether the percentage business is better or do we follow that? Ideally.
First, I'd like to just get a consensus from shoulder surgeons on what they would like it reported as.
So in our books, generally,
No,
if it's okay. So for me, what makes sense for me is percentage. Like if it's more than 50%,
but if you could
it's
go
hanging
to
on,
the shoulder society
and get
me
that
a document that says we want all to be reported as 1, 2, 3, and give it to the radiology society, then we're happy to follow. But okay, so just I mean, jokes apart. What I think, what we try to do, and as I try to, what we are showing you on MRI is the degree of disorderliness of collagen, okay? And what I try to express to you is how much collagen is bad in two ways. One is in terms of the craniocaudal thickness of the tendon, and two is in terms of the AP width. So I would tend to say that there is, so we use two terms. We use partial thickness and partial width, or full thickness and full width. So for example, if there's a tear just of the anterior supraspinatus, we'll say a full thickness partial width tear of the anterior supraspinatus. And then we'll try and give you percentages in terms of what proportion of the footprint is involved, so that you know how big that tear is antero-posteriorly. And our thinking, at least of it, is when we give you that information, it gives you some insight into, is this one anchor, is this two anchors, is this three anchors, and helps you to estimate things that you're going to have to do for the patient.
There's one more observation to that.
Yes, of course. That always, whether it's fatty infiltration or not, and those things.
There's one thing different to it. When we talk in terms of percentages, and we are nowadays getting more Google patients. So they will go with this percentage values, go to the Google, try it out, and one you will say that, okay, let's conserve it. Your fellow orthopedic surgeon is going to say, okay, let's operate it. And Google is always going to give them wrong information. So when we give this fixed percentage, they create a more gray zone where the patient then starts to distrust the doctors. So in that scenario, I'll put like partial thickness tear, anterior fibers, middle fibers, or the entire thickness of the...
No, I sort of disagree with that. I think that most of these patients that we conserve, we want to follow up and see if there is an extension of the tear, is that increase, decrease. So in that case, the percentage value, at least if not reported, at least on your reporting or on your referencing, should be important, because that will help us know the progression of the tear.
That is in follow-up scan.
Of course, yeah. So that is another point that, where percentages come into play.
Don't get follow-up scans coming to the same center.
That is not,
we
try to do that, or if the patient comes to the same doctor.
But I think you're right. I think you're absolutely right. There has to be some sort of quantification that we follow, and there has to be some sort of way. So we tend to use terms like anterior third, mid third, posterior third. And that just sort of helps to give you a sense of, okay, this is just a small little thing in the front, or this is a big thing that's involved in the whole thing.
Can I just say something, Chintan?
Yeah.
Do the patient's clinical symptoms always correlate with, the amount of partial tear? They don't. To be honest, in my books, MRI is not really a diagnostic tool. I get an MRI when I want to plan surgery, to know whether a tear is operable or not. By that time, clinically, you know that they have a rotator cuff tear. You've tried physiotherapy. You look at things like retraction, fatty infiltration, amount of atrophy. I think those things are more important than the amount of fibers, or whether it is tendinosis or tendinopathy. Because a lot of times, clinically, as you rightly said, what they have is a frozen shoulder. And all these tendinopathic findings would be there in probably a lot of shoulders which are clinically asymptomatic.
So the idea really, in the interest of time, just quickly, the idea really for doing an MR in situations is that you just want to make sure that, okay, your clinical diagnosis is tendinosis. You want to reconfirm that it is tendinosis and there is nothing else there. There is no adhesive capsulitis. I've seen plenty of patients who come in with, they've got tendinosis, nothing much, and they've got big calcific tendinitis. Or they've got, something that would potentially change management. That's what you're looking for. If you're convinced that there's nothing else, you're not going to do anything with the patient no matter what, maybe you don't want to do it. But sometimes you do end up getting the imaging just to make sure, okay, I think this is a tendinitis case. I just want to make sure it's tendinitis. And if it is, I want to get a sense of how bad it is. I may not even be, the goal may not be to operate on it. The goal may be just be to document, to show the patient, look, this is exactly what it is. We are on the right course. This is our plan of management.
Maybe you can get an ultrasound done just, if you want to rule out, it's not a full thickness tear.
Yeah.
When we have MRI available, I mean, I don't see why. Unless there is a patient who's scared to get into the gantry, otherwise I don't see a reason why I should get it done.
So let's just quickly go to this case. Would any of the, I'm just going to, in the interest of tell you that all of these ligaments look relatively intact. So this is an ankle MRI. This over here is going to be your calcaneofibular ligament, which you can see here. You can see it here as well. Here's the deltoid. Here's the tibial spring ligament. You can see the deltoid and the tibial spring ligament here. Anterior, posterior tibiofibular ligaments. All these ligaments looked pretty good. They were intact on MRI. And what we ended up getting was a yelling, screaming orthopedic surgeon who sent us this image showing us this translation on the ankle and showing us this dynamic evaluation of the ankle. And the question is the radiologist wrong who is reporting the MRI? Is the orthopedic wrong or too forceful in his stress loading? Is this a radiologic orthopedic discord that is explainable? Or is this something that is inexplicable? This is useless, we should stop doing MRIs forever, we should just do dynamic X-ray evaluations. Anybody from the audience? Anybody from the audience want to take a crack at this? Since everybody here has put their hands up and says bugger off.
Hyperlaxity syndrome.
Okay, that's one thing, hyperlaxity syndrome. Anything else? Anyone else?
So we see a few amount of ankle instability, I would say, or ankle sprains. When they come with ankle sprains or something like this, we don't do anything. We just give rest. But there are people who come with either impingement when they say that in a particular moment it impinges. They may or may not get MRI for us. But if they say that it feels unstable, especially walking on the rough surfaces, or when they went back to their...
Just stop you for a second. My question is simple for this, just for the minutes of time. You have an MRI that says all the ligaments are normal. You trust this radiologist. You're a supreme radiologist yourself. You looked at it and said, all these ligaments look normal to me. Somebody sends you an image that says, book. What's going on?
So, I mean, I really think the clinical exam, is more prominent for me.
But that's fine. I mean, we're agreeing the clinical exam is showing it. We're agreeing that this is happening. But can you explain this? I mean, should you be putting your arms up in the air and saying, what a useless radiologist, whose MRI is all crap, burn it to the ground and let it go to hell? Or can you explain why this is happening?
So, I will just give an example. Like, a lot of times we have shoulder dislocation and they come back and they literally we cannot find.
Done.
So, it happens with us.
Agreed, done. I'm saying, can you explain it? That's all I'm saying.
The discord is between the clinical observation and the radiological...
There is a discord. Can you explain the discord?
Ehlers-Danlos or something like that?
Yeah, lax ligament. So what I wanted to actually just bring out from this case is that ligamentous laxity is something that's very difficult for us to demonstrate on MR. So when you have an injury, you may stretch a ligament and then may remodel into a slightly lax position. On MRI, that structure will still look continuous, okay? But I'm not putting under dynamic load, so I can't see what's happening with it. I may see patients with an ankle sprain who have had previous ankle sprains. I see the ATFL, CFL, everything looks intact, but they have a big osteochondral lesion in the talar dome. I know they're unstable. But, why are they unstable? Because these ligaments have remodeled. And some classic places that you're going to see this, these areas of discord, one is going to be, for example, in a PCL tear. So when you have a PCL injury and it's chronic, a PCL injury will typically show up with a fairly innocuous appearance. So you do a PCL, somebody gets an injury, they get up, they walk, you don't even know you've torn your PCL. About 3 months later, they come back to you saying, listen, my knee I'm still feeling weird, I feel pain, this, that, and the other. You do a clinical exam, you say, boop, it's gone all the way back, your posterior draw is positive, you know that they're lax. You get an MRI, the report comes back saying PCL looks normal. You're like, what the hell happened here? So this is typical of the PCL. The PCL is a structure that remodels extremely well. So when you look at it on the MR, it looks perfectly normal if it's chronic and it's healed, but you do have persistent laxity. Another place where this problem happens is when you look at the posterolateral corner. So you have ACL injuries with a PLC. When you look at them later on, maybe a year later or 6 months later, they come to you for ACL surgery. You say the ACL is gone for sure. You're pretty sure that there's your dial test is positive. You've got a pivot shift. You're saying, okay, this is all pretty cool for a PLC. And the MR comes back saying PLC structures look normal. So these are two places commonly where you see ligamentous laxity that you may not see on MR. And in these situations, this is where you say that there is some role for early imaging. So when you do an early MR, somebody post-injury, you will see all these structures look horribly injured. So somebody will say intermediate to high-grade injury of X or Y or Z. And you'll say, but it doesn't look that bad. And you'll wait for everything to come back. And on a delayed image, you'll just see laxity. So I think it just wanted to drive home the point of timing and of this discord. When you see laxity versus your common imaging findings, you can see this discord commonly because of that. Okay, I'm quickly going to go to this case. We probably have another 5 minutes, so let's just quickly go through this. Anybody want to take this case? Here's a patient who presents with ankle pain and swelling. This is a scan from January 2021, and this is now almost a year later. The persistent finding is this bone marrow edema at the distal tibial plateau. And anybody have any thoughts? Sorry?
Impingement syndrome.
Okay, impingement syndrome is a good thought. That's what we were thinking about. Anybody else? And honestly, I might have even called it that before my partner picked up the finding, because she's much better than me. So a calcification is something you would think about. What else?
What's the age of the patient?
This young guy, like 20 something, due to get married.
Inflammatory arthritis.
Inflammatory arthritis. Yeah, that was another thing that ran through my head as well.
There's a synovial hypertrophy on that.
Synovial hypertrophy, everything else, I agree with you completely. Does this catch your eye at all? This thing here?
Do you have a CT cut? Is that an osteoma there?
Yeah, so this is a great case. So this is a case where actually this patient persisted with persistent pain, swelling. When we asked him further a bit deeper, the pain ended up being more at nights, required things. And then when you look at this MR now a little bit more closely, you can see the bone edema. You can see this tiny little nodule over here. And on the CT, you see this small little osteoma, which we went ahead and did a radiofrequency ablation for. And the patient is now doing exceedingly well. So the point of this case really is that when you see persistent bone marrow edema and you see synovitis, your brain should start to, in a young patient, your brain should start to think about the possibility of an osteoid osteoma. And the typical thing with an osteoid osteoma, most of us see it along the shaft and in the cortex, where we see this clear, lytic focus with sclerosis around it, and we're pretty sure it's an osteoid osteoma. When there are intra-articular osteoid osteomas, they tend not to produce so much sclerosis. So you just see this intense focus of bone marrow edema, and you don't even actually see the lesion unless you do a thin cut CT. So here is, for example, a patient with an X-ray, which looks pretty normal. And when you do the MR, you can see this small little focus within the medial cortex of the bone with extensive edema, which was an osteoid osteoma. Here's another example where you see a little bit of bone edema here around this at the neck. Again, you see a lot of synovitis, and then when you look at the CT, you can see that osteoid osteoma there. Here's another example. This X-ray looks bang normal. This CT looks, close to normal. We went back to look at this MR, and on the MR, there's bone marrow edema in this acetabulum as compared to the opposite side. On the bone scan, you can see there's increased uptake in that acetabulum that's rather discrete. And then when you go back and look at it a bit carefully, there's this small little subtle lytic area here, which actually ended up being an osteoid osteoma. So this was a small little osteoid osteoma in the acetabulum. And we had a similar case on this young kid where we had this edema in the back here. You can see this small little osteoid osteoma here. And here we did a dynamic contrast study where you can see that osteoid osteoma lighting up. And this was that, and we actually did a radiofrequency ablation for this lesion as well. And this kid's story was incredible. She would come yelling and screaming into the office. You literally put 2 drops of medicine into her mouth, and pain was all gone. So it was this thing. They can occur also in some unusual locations. So here's an osteoid osteoma. It's a shoulder pain patient who had an arthrogram actually somewhere, and there was actually this lesion right in the back here, which was an osteoid osteoma at the base of the coracoid process. Here's a patient who had a lumbar spine MR, which looked normal. You can see a disc coming out towards the left, and we said, okay, the disc disease related pain. You look at the MR, you see intense bone marrow edema here in the neck, and this patient actually had an osteoid osteoma in the femoral neck. we have 1 more minute to go, so maybe I'll just go through these cases, the last two. So one is here, this is one where we see, this was just a case again to bring to light this whole issue of when we see intense marrow or soft tissue edema patterns, what to think about. So we always tend to default to infection and trauma or something like that, but oftentimes the history doesn't match up. So if you see very intense edema, so such as this case, this is a coronal image from an MRI, this is the clavicle, this is the coracoid process, and you can see here the coracoacromial ligament here. And along the coracoacromial ligament, you can see this area of intense inflammation, and within it, there's a small little hypointense focus here. And this actually turned out to be a patient who had calcific periarthritis of the coracoclavicular ligament. So anytime you see intense soft tissue edema, sudden onset of symptoms, no history of major trauma, just disproportionate pain and trauma, remember in your mind to just trigger the thought of calcific. And what ends up happening in these cases, unfortunately, is because our knee-jerk reaction is to do MRIs, we get the MRI done and we don't see the calcification, which would be just blatantly obvious on the X-ray. So I think it's one important thing. For spine guys, I think longus cola is a common area where you guys will see it. So this was just an article we wrote about atypical locations of calcifications in the shoulder. So this is the last case we have here. This is a patient who had bone marrow edema in the femoral head. And the question was whether this is AVN, transient osteoporosis, a subchondral insufficiency fracture, or inflammatory infectious arthritis. And would anybody just like to quickly shout out the answer? Sorry? Anybody?
Insufficiency fracture.
Yeah.
Close to joint.
Perfect.
And it's nicely
Great.
contoured along the joint level.
We have the next session starting, no? Is the next session people here yet?
Yes.
Go ahead. Just tell us to stop and we'll stop. Are we enjoying our session? You're supposed to like turn off the lights and start yelling and screaming unless you're so enthusiastically enjoying our cases. So I just quickly, transient osteoporosis is an entity that's really not considered to be real anymore. Almost all of these cases are what we call subchondral insufficiency fractures. They present with intense bone marrow edema and they can go two ways. They can just resolve, and the ones which resolve we used to call transient osteoporosis. And the ones which progress to rapidly progressive osteoarthritis, those are the ones we end up calling spontaneous osteonecrosis. But fundamentally, it's a subchondral insufficiency fracture, some of which heal, some of which don't heal. So I'm going to go ahead and stop. Thank you, everybody. Thank you to the panelists, everybody else who was here.